would like to ask Olga Salazar, if I say it correctly, to the stand. She is from Connecticut. She's a pediatric cardiologist and does a lot of work on cardiac toxicity in our pediatric oncology children, and we're very honored that she wants to give this talk here.
Well, good morning, and thank you for that kind introduction. So in the next few minutes, I would like to discuss the cardiotoxicity of most commonly used chemotherapeutic agents, risk stratification of patients exposed to cardiotoxic medications, the early imaging and biomarkers for assessment of cardiac injury with take-home points and future directions. So there has been a significant decrease in the mortality in patients that have cancer, and that's due to the increased number of anti-chemotherapeutic agents. But unfortunately, most of these patients are living with side effects from these medications, with cardiovascular morbidity and mortality now secondary to recurrent malignancies as a significant long-term complication in these patients. So most of the chemotherapeutic agents have a cardiotoxic potential, and some of them we know better, such as the anthracycline antibiotics. But if we look at this number of chemotherapeutic agents, we'll see that most of them will have some effect. The antimetabolites have a 1 to 7% risk of cardiotoxicity. Typically with those medications, we see changes in the vascular system leading to angina, changes in ST and T-wave changes on the EKG. The taxane medications are antimicrotubules that can affect calcium metabolism, leading to bradycardia and AV block in some of these patients. There has been also reports of tachyarrhythmias, including atrial flutter and atrial fibrillation that can occur, but it's thought that most of that is related to the vehicle, the castor oil that is in some of these medications. Alkylating agents are commonly used in patients with cancer, especially our child cancer patients, and they can cause significant myocardial damage when used in combination with anthracyclines and with radiation therapy to the chest. Cisplatin and platinum agents can lead to significant vascular changes. Those patients can have systemic hypertension, changes in the vasculature leading to coronary artery disease as well. Anthracycline-induced cardiotoxicity is the better known of the medications that cause cardiotoxicity, and we know that that is caused by the oxidative stress that is caused by the formation of these oxygen radicals that lead to protein and nucleic acid changes, lipid peroxidation, and eventually lead to cell apoptosis. We also know that there is an effect on topoisomerase 2 beta that is present in the slow replicating cells in the myocardium, and that leads to double-stranded DNA breaks that eventually lead also to myocardial cell apoptosis. Interestingly, there's also alterations in the MDR. This is the ABBC cassette of proteins that extrude the anthracyclines out of the myocardial cells, and that can increase the levels of these medications and therefore increasing their toxicity. And lastly, and very importantly, there may be a decrease in the mesenchymal and circulating progenitor cells that lead to a decreased regenerative potential of the myocardium. The HER2 or ERVV2 target therapies can also affect not only the myocardium but also the endothelium. That leads to systemic hypertension. These medications, such as trastuzumab, are commonly used in the treatment of breast cancer in addition to the anthracycline antibiotics. They also cause a disruption of the RBB2 receptor with the NRG that lead to disrupted coupling in the myocardial cell with decreased response in stress and myocardial damage. Small molecule tyrosine kinases have a similar effect. They both affect the vascular endothelial cells with impaired vascular function, increasing risk of atherosclerosis, but also block the tyrosine kinases in the myocardial cell, lead to impaired myocardial function and impaired response to stress. Part of the complications related to cardiotoxicity is that we have a very limited definition of cardiotoxicity that is just looking at the global function. And what we can see in this slide is that these medications can affect the cardiovascular system at multiple levels. So on the right hand of the slide, you can see that platinum-based therapies, antimetabolites, and radiation therapy to the chest, as well as some of the HER2 and and the tyrosine kinase can lead to changes in the vascular system. We have damage to the endothelium, systemic hypertension with increasing in systemic vascular resistance that further affects the myocardium. In addition, we have the medications such as, again, the HER2 medications, the anthracyclines, and alkylating agents that have a direct effect on the myocardial cell. As mentioned previously, microtubule inhibitors can lead to changes in the rhythm of the heart, calcium metabolism, leading to AV block and bradyarrhythmias. So it is very important that when we think about cardiovascular toxicity, we have a better and a global approach to this problem. There has been reports of fulminant myocarditis with combination immune checkpoint blockade, and in this type of medications, the T-cell effect on the myocardium is blocked, therefore leading to a fulminant myocarditis. As you can see in the left upper panel, this patient has a complete AV block, leading also ventricular tachycardia. There is diffuse infiltration of the myocardium by lymphocytes, and also infiltration of the muscle cells and this typically leads to fulminant myocarditis and death. So I would like to use anthracycline cardiotoxicity as a model of how we can study these medications. We know that anthracyclines cause acute myocyte damage, that this occurs during the duration of therapy. Let's just go back to that. And that this leads to structural changes in the myocardium that eventually lead to heart failure. So we've been working on a preclinical model of cardiotoxicity. We're trying to understand the diversity in response to cardiotoxic effects of these medications by using a diverse model of preclinical diverse model in the mouse. And what you see here is that in the acute changes in the acute stages of cardiotoxicity, you see some myocyte hypertrophy, as well as some vacuolization that is due to the dilatation of the endoplasmic reticulum. In the chronic changes, you see significant changes, including microscopic fibrosis, significant myofiber disarray that leads to typically heart failure. In trying to understand a little bit better the pathways of this, we went ahead and do some immunohistochemistry stains that show us some of the typical findings of adverse cardiac remodeling that include microscopic fibrosis, infiltration of the myocardium by macrophages. We know that cytokines lead to changes in heart failure, as in other models that have been studied. The collagenases such as MMPs, MMP2, 7, and 9, that contribute to the breakage of the extracellular matrix, and also caspase-3 as an indicator of myocyte apoptosis. In the chronic changes, as you can see here, in one of our docs induced chronic models compared to controls, there is significant interstitial fibrosis and significant infiltration by macrophages and SMA-positive cells that indicate the differentiation of the myocardial cells to a most embryonic form. This is an example of what we have seen based on our cardiac scoring. The cardiac scoring was performed in these 10 different mice with different genetic backgrounds. We have multiple clones, so we're able to use controls in the gray and treated mice on the red. And you can see that some of the strains are extremely sensitive to the medication, while some of the strains are significantly resistant. Understanding these differences would be very important in developing strategies to prevent cardiotoxicity. Most of our patients that are exposed to cardiotoxic medications are already on stage A of heart failure. That is at increased risk of having complications related to these. It is important that we target the early stages, stage A and B, for prevention of this complication. We know that once patients develop stage C and D of the disease, that they're going to have a significant increase in mortality of 50% in 5 years. So based on our cardiotoxicity model, we know that AIC is caused by exposure to anthracyclines, but that is modulated by the risk factors that include genetic predisposition, early age, the exposure to other cardiotoxic medications, radiation therapy to the chest. So it is very important that the individual risk of these patients is being taken into account when trying to identify who would be at increased risk. We know that these changes cause damage in the myocardium that include changes in the extracellular matrix, as well as myocyte apoptosis. And that these changes lead to what we cardiologists call adverse cardiac remodeling, which include myocyte hypertrophy and microscopic fibrosis that eventually leads to the development of heart failure. So we looked at the risk factors in our patient population, and as expected, the cumulative dose of the medication, radiation to the chest, and previous heart disease were significant findings that were correlated in these patients. We were the first to describe the significant impact of shortening fraction as a measurement of myocardial dysfunction in long-term mortality in these patients, as is seen in this slide. We went on to look at the effect of risk factors on all-cause mortality, and we identified that having a shortening fraction less than 29% at any time during therapy significantly increased the risk of death in this patient population. I will just mention that based on our findings, we're trying to develop risk stratification models to identify patients that are at low, intermediate, and high risk. And I will let Dr. Orsi, who will speak later, discuss this a little bit farther for you. As mentioned before, one of the significant issues that we have right now is a very limited definition of CTRCD that is based on just changes in global function, with no pediatric guidelines available. So we need to go beyond quantification of ejection fraction and to look at evaluation of myocardial deformation and adaptive microstructural and microvascular changes to understand this disease better. This slide exemplifies what happens in the pediatric population. This is an early cardiotoxicity cohort, and we can see that most of our patients start with ejection fractions that are extremely high, higher than 55%, and that most of them, as you can see on the right-hand panel, are going to have more than 10% decrease in ejection fraction, but yet, based on current guidelines, they wouldn't meet that definition of cardiotoxicity. What we found in our early cardiotoxicity cohort is that we see gradual changes in ejection fraction, and that these are at the expense of increasing end-systolic volume index. So we can use this end-systolic volume index as an early correlate to decreasing global function, and we'll talk about this a little bit more in the future. So these are examples of a cardiac MRI, and I'm not sure if this, yeah, I think they're playing, that's wonderful. So on the left-hand panel, you have a shortening fraction, you have a short axis view of the heart, and this is one of our chronic patients, unfortunately, a patient that died awaiting transplant therapy. You can see that that patient has already decreased global right and left ventricular function, that there is bilateral pleural effusions and pericardial edema. So we really need to impact this a lot earlier. We know that EF is insensitive to alterations in regional performance and may conceal underlying regional dysfunction. So we want to move ahead and try to look at the regional myocardial function. And here is the concept of myocardial strain, that the global function of the heart is dependent on multiple myofibers in the heart, and that we can measure these myofibers function typically in three directions: radial, as the heart squeezes inward; longitudinally, as the heart squeezes in the long axis direction; and circumferentially. So this concept of myocardial strain is defined as that a percent change in length in these three directions, with radial strain being a positive change, circumferential and longitudinal strain being a negative change. And now we know that changes of more than 15% from baseline, as well as a decrease in strain of more than minus 17% being a significant finding. And this is how we measure strain by cardiac MRI, and unfortunately, I don't think these movies are playing. But what you see here is that we have, let me just try that again. Perfect. That we see, what we would see if these movies were playing is that you see myocardial deformation. We apply modulation lines into the cine images on the cardiac MRI, and we see changes in those myocardial tagging that we can then look at in post-process strain, and I'll show you how we do that. So we track each one of those regions, and we go through systole and diastole, and that's how we assess the percent change. So you can see that in this case, we have changes in strain at the basal, mid, and apical slices. This is one of our chronic cardiotoxicity patients, and you can see that there are significant reductions in strain despite a normal global systolic function. This is new methods that are being developed in a cardiac MRI, where now you can do ultra-fast strain imaging, and you can have color-coded images here. So you can see that there is normal function as depicted by the blue, with hypokinetic agents depicted as yellow. So we could have ultra-fast sequences that can be done and can be very helpful for the evaluation of these patients during and after therapy. These are some of our results of tag imaging strain in early cardiotoxicity. So we analyzed these patients at set dose intervals, and what we discovered was that longitudinal strain magnitude changes in ELL occur much earlier than changes in global circumferential strain magnitude, and that these precede changes that occur in global systolic function, or EF. We demonstrated similar changes in our chronic cardiotoxicity patients, and these slides demonstrate the changes in strain, as you can see on the right-hand panel, on the patients with cardiotoxicity. This was a group of 60 patients that have normal global function, and you can see that there are significant changes already in global and circumferential strain magnitude, not only globally, but in all segments of the myocardium. There are other techniques that can be used by MRI to look at the tissue of the myocardium. This is T2 mapping, which allows us to look at myocardial edema, and could be very helpful in the diagnosis of myocarditis in these patients. More importantly, now we're able to look at microscopic fibrosis. Remember, I mentioned that some of the changes that we see in cardiac remodeling are increases in interstitial fibrosis and increasing the extracellular volume. With T1 mapping techniques, we can now then measure the T1 value of the myocardium, and we can identify microscopic fibrosis. With the use of gadolinium, we can also look at the extracellular volume. Knowing that volume of distribution of gadolinium, we can actually assess what percentage of the extracellular volume is caused by increasing fibrosis. So these are some of the changes, some of the findings that we saw in our chronic cardiotoxicity study. We saw increased T1 mapping changes pre-GAD, and decrease in T1 changes post-gadolinium, indicating the presence of microscopic fibrosis in these patients. In addition, we showed higher extracellular volumes that were especially seen in female patients, as is seen here. So that portion of the myocardium that is increased by the presence of interstitial fibrosis in these patients. We know that these changes are correlated also with increasing cumulative dose, with performance as measured by VO2 max and by exercise testing, and also by decreasing mass volume and myocardial thickness dimension ratio. Since echocardiography is used in the routine evaluation of these patients, we then went on to look at the feasibility of echocardiographic techniques to detect subclinical CTRCD among our patients with anthracyclines. And not surprisingly, we found that in systolic volume more than 29 mL per meter square, three-dimensional global longitudinal strain, and decreasing the early atrial myocardial velocity as an indicator of diastolic dysfunction were earlier markers of cardiotoxicity. When looking at the three methods that we use for typical measurement of ejection fraction, Simpson's biplane, area length methods, and 3DE, we found that 3DE was the most closely correlated with the ejection fraction obtained by CMR. For the audience who is not a cardiologist, I just wanted to show you how we look at this diastolic dysfunction. The E velocity represents passive filling during the cardiac cycle, and the A velocity represents atrial contraction. So what you see in patients that have diastolic dysfunction is that In the second panel, you see a decrease in the E velocity and also the tissue Doppler E velocity that we measure in the myocardium. That implies that more of the filling of the heart is dependent on the atrial contraction due to decreasing compliance. So these early changes in tissue Doppler E velocity, less than 10 in our pediatric population and less than 8 centimeters per second in the adult population, may be significant early markers by echocardiography of diastolic dysfunction. And this is just to remind you how we measure myocardial strain by echo. I mentioned the global longitudinal strain. As demonstrated in our study, both 3D global longitudinal and 3D circumferential strain magnitude were the most significant changes that were associated with our findings by CMR. Moving into biomarkers, there has been a lot of work that has been done by many investigators related to the use of both troponin and NT-proBNP. There was a previous poster that was a paper that was presented here in this conference. This was a publication by Dr. Lipschultz that demonstrated that there are troponin elevations with increasing doses of anthracyclines, and that this can be blocked by the use of dextroazoxone in these patients. There's also been significant work that has been done on NT-proBNP. There have been a few studies that have shown that higher baseline concentrations of NT-proBNP can predict the development of overt heart failure after cardiotoxic chemotherapy. And cutoffs of natriuretic peptides that could play a predictive role are still elusive, and I think that there were some, the paper that was presented here was discussing levels that were much lower than what I'm showing here, but NT-proBNP levels of 300 and 500 nanograms per ml may indicate which patients could be at higher propensity for further heart failure. Having learned what causes adverse cardiac remodeling in our patients, we decided to look at both MMPs, which are gelatinases that destroy the extracellular matrix, as well as cytokines receptors as a measure of cytokine release by inflammatory cells. And we identified a pattern of proteins that are elevated earlier and that predict decreases in ejection fraction more than 10% in our patient population. We found that MMP2, 7, and 9 are upregulated. TIMPs, which are inhibitors of the metalloproteinases and may lead to microscopic fibrosis, were also upregulated in these patients, as well as multiple cytokines. Moving a step farther, we wanted to look at microRNAs. MicroRNAs are modulators of myocardial stress, and these are very good biomarkers. And we decided to look at an array of 84 cardiac-specific microRNAs. And what you see on this slide on the blue bar, you see that there is the early point in our early cardiotoxicity study. The red bar corresponds to the end of therapy. And you can see that early on, the microRNAs that are related to acute damage and toxicity are upregulated, while at the end point of therapy, microRNAs that are related to growth and development are downregulated. So this has significant implications and potentially can be used in the early identification of cardiotoxicity in these patients. And finally, there has been extensive work that has been done in terms of genetics. We know that there are certain genes that predispose to cardiotoxicity. This is mostly related to how these drugs are metabolized. We know that changes in the ABBC cassette, as mentioned previously, and how these anthracyclines are extruded from the cell can be significantly important. So understanding genetic susceptibility is going to be a key player in identifying patients at risk. So we are in need for validated biomarkers that are surrogate endpoints for clinically important cardiovascular disease and treatments that prevent and control CTRCD. And a cross-disciplinary approach has the best chance to identify and treat cancer patients at risk for cardiotoxicity. We hope to develop comprehensive, evidence-based, personalized prevention, detection, and treatment strategies for CTRCD, new knowledge on the molecular mechanisms that activate susceptibility and resistance to CRTD will inform new therapeutic approaches in these patients. Insights into these regulatory pathways responsible for CTRCD and developing a biomarker signature early of myocardial dysfunction will allow us to identify patients most at risk for the severe toxicity, as well to evaluate potential therapies for heart failure. Thank you.